I was asked to come and talk about what I did when I was the Undersecretary for Health for the U.S. Department of Veterans Affairs, although I should quickly point out that I haven't been there for a long time. That was something that occurred in the late 1990s. After I'd left there, I established the National Quality Forum and ran a large health information technology company and have done a number of other things, and I'm currently at the University of California, Davis. So let me, and I'm mindful that we have relatively short period of time, and I appreciate your willingness to spend the next 45 minutes or so with me. What I was asked to talk about was as I said already, the changes in the VA healthcare service that when President Clinton asked me to go there in 1994, the basic issue was, is this a system that can be salvaged? Does it have a future? There were many at the time who said no, and so my charge was to see if we could do that. What I would like to walk you through very briefly, because of the time, I mean, how we reformed the largest healthcare system in the United States in 40 minutes, basically. I wanted to talk a little bit about the strategies and tactics that were used to transform this large public system, and then end with a few observations or what might be even considered lessons of this exercise in change management. Before I do that, I would be remiss if I didn't at least acknowledge where I am today and who pays my, or makes out my paycheck. And that's at the University of California, Davis. And I was asked a couple of years ago to come back and launch what I called the Institute for Population Health Improvement. And time doesn't allow really to say much about it, but it's been in existence for just about 2 years. During that time, we've been relatively busy. When I went there, I was the first employee. We had no funding. We now have over 100 staff and $71+ million in extramural funding. And I would be also remiss if I didn't make the point that any healthcare system today that hopes to thrive, I would posit even to survive in the new healthcare economy that is on its way towards us, has to be competent at population health management as well as clinical integration. These are just two basic skill sets that at the moment most healthcare systems don't have, but they're going to have if they hope to continue doing business. We work a lot with the state government. We have some work with both the federal and local government, and as well as the private sector. But most of our portfolio is with state agencies. I see some folks from those agencies sitting around the tables here. Time doesn't allow us to go into some of the work that we're doing as far as quality improvement in Medi-Cal or health information exchange or public health improvement and other things. But the last point I would leave you with regard to IPHI is simply that a lot of what we are focused on is promoting understanding that there are a lot of things that determine health, and when we think about population health, healthcare is a relatively small component of that. Indeed, the numbers would suggest 10, 15, 20% of what makes a population healthy is related to healthcare. It's much more important, or things like education and employment and a clean and safe environment, and we can go down the list of what's often called the social and environmental determinants of health. Indeed, I would posit that the single most important thing we could do to improve the health of California, indeed of the nation, is to increase the number of college graduates. It has really nothing to do with healthcare per se. Enough of the editorial comments. Let me move on. So the question that you might be asking yourself is why should we discuss the VA? And as was noted, it was a large change management effort that seemed to have met with unexpected success. Indeed, when I went there, there was universal consensus that if there was ever an organization that was so politically complex and sclerotic and full of vested interests and, go down the list of other pejorative comments, it was the VA, and that there was absolutely zero chance of ever making meaningful change. Not too many years later, we have the Harvard Business School, the Yale School of Management, the USC MIT, School of Man, others writing case studies about what was dubbed radical organizational transformation. It's been called the largest and most successful healthcare turnaround in U.S. history. So if for no other reason, that's probably a reason to hear a little bit about it. The strategies that were used to transform the VA healthcare system are, in essence, the same strategies that are being used elsewhere more broadly in American healthcare. Use of information technology, looking at population health management, integrating care, improving quality. We could go down a relatively short list of change drivers. And many people have found that just from a simply organizational point of view, ignore the content matter or what the organization did, but just as an organization change case study, it provides some lessons and may be instructive. I find, actually having worked in both the private and public sectors of healthcare, that the VA is much more like the private sector than most people acknowledge. It has a different payment model, different business model, but has all the same issues. When I was Director of Health for California for most of the 1980s, and when I left there and after a couple years of hiatus in academia, then went to the VA, I found, like this is the same stuff we were dealing with California in the private sector, the same issues, the same problems. The main difference was in the VA, they all get vetted and aired in the public domain. The private sector is much better at not having some of those things appear in the newspapers. And perhaps the last point I would make is that the results of what happened in the VA actually have been well documented now. Hundreds of papers, doctoral theses, books, other things have been written about it. And some parts of what happened have actually been well studied as far as the change process. So there's actually some evidentiary base behind some of this. It's not just the usual Washington rhetoric. So let me just start with a brief, how many people here know anything about the VA, ever worked in the VA? Okay, so a fair number. Hopefully most everyone can spell VA. But let me just do a quick overview of what the system is about. It's managed by the Veterans Health Administration, which is a sub-cabinet agency in the U.S. Department of Veterans Affairs. The VA, or the Department of Veterans Affairs, is the second largest agency in the federal government, behind the Department of Defense, and then Department of Homeland Security and Health and Human Services would be the fourth largest agency. Just like the Health and Human Services has a number of sub-cabinet agencies, CMS, Food and Drug Administration, NIH, there's 11 sub-cabinet agencies in HHS. VA has a number of sub-cabinet agencies as well. VHA, or the Veterans Health Administration, is one of those. And again, just the Veterans Administration, which some people still use, hasn't existed for 25 plus years, for those who are interested in that little factoid. Anyway, the VA healthcare system was established in the early 1900s, over actually 3 decades. It didn't happen all at once, but was incrementally established to provide a safety net for poor and disabled veterans. There was actually a landmark in health policy in 1924 when the Congress enacted law to provide care in the nascent VA healthcare system for poor persons, poor veterans, which actually antedated by several decades the same step being taken for the rest of the citizenry. At the moment, and for some time, VA has been the largest healthcare system in the U.S. And I would also say it's a bit more holistic than most of healthcare. Things like transportation and vocational rehabilitation and other things that typically aren't covered by healthcare are an integral part of what the VA does as part of the healthcare portfolio. It's the only healthcare system in the U.S. that has facilities in all 50 states, every major or significant metropolitan area, as well as a number of places outside of the continental U.S., Guam, the Philippines, Puerto Rico, et cetera. The population that VA takes care of is sicker, poorer, otherwise more disadvantaged, less white, less well educated, go down the list of things that people in healthcare try to avoid. That's the VA population. There's a very high prevalence of mental health and behavioral health problems. Probably the closest or most analogous population is the Medicare, Medicaid dual eligible population, of which California is trying to do some good things there. VA is very much involved in health professional training and education, and just as far as some vital statistics, last year there were about 8.3 million enrollees, had an operating budget of about 49 million or 49 billion, and I distinguish that. It also has a construction budget and some other things, so the total budget is a bit more than that, and had about 1,400 facilities or sites of care. Most veterans in the United States are not eligible for care in the VA. Again, a common misperception that all veterans are eligible for care. Actually, most are not. I'm a veteran and I'm not eligible because I'm not disabled and make too much money. It's a safety net system, and there's about of the 22 million or so living veterans right now, about 37% are eligible and enrolled in the VA healthcare system. Unlike the military healthcare system, which is a separate and distinct from the VA, dependents and family members with a few very small exceptions are not eligible for care in the system, which creates some interesting gender and other dynamics. I mentioned VA is very much involved in health professional education, funds about 10% of all the graduate medical education positions, 85% of the hospitals are teaching hospitals. Overall, about 110,000 trainees rotate through VA facilities each year in 47 different types of health professions. The VA is actually the largest provider of care for nursing, for pharmacists, for optometrists, for podiatrists, for a long list of other types of healthcare workers. And indeed, one of the issues when people say, well, let's just voucher out veterans and do away with the VA, they ignore things like what's going to happen with all that health professional training that's being done, or the research. The VA is a very illustrative history of conducting research, has about a $2 billion a year research portfolio, and it does some other things like assist in federal emergency situations. When there are tornadoes or hurricanes or floods or fires, often VA deploys staff there immediately to assist in the recovery efforts and serving the casualties. And lastly, one of VA's unwritten, most of the things I've just talked about are statutorily mandated missions. The fifth core mission is taking care of homeless individuals, and that's often called the fifth mission of the VA. And simply because about 35 to perhaps as many as 40% of the adult homeless in the United States are veterans, although the current secretary has put this as a very high priority, and there's actually significant inroads being made in that regard today. So, and just the last thing I would say, when I left the organization in 1999, this was kind of this was a listing of our assets: 172 hospitals, several hundred clinics, a fairly large number of nursing homes, and large residential care facilities. VA calls them domiciliaries, and the private sector we call them residential care, but in some cases several hundred beds in these. Counseling centers, partners with the universities, and lots of sharing agreements for lithotripters and PET scanners and other high capital or high cost capital investments. VA is also the largest laundry service in the world, something that I know you probably didn't appreciate. But actually, as part of the work therapy and compensated work training programs, does laundry for many private healthcare systems. It also has a retail store, national retail store system where you can buy anything from a car to a toaster oven to a boat to clothes, anything essentially you want. And it also manages more historic sites than any entity other than the Department of the Interior. I go through this, and it's a relatively complex organization. Healthcare is complex enough. VA has a number of additional wrinkles that makes it perhaps a little bit more complex than some other large healthcare organizations. So, what was wrong with the system in 1994 when I went there? Indeed, the striking thing was that there was little, if any, disagreement about what was wrong with the system. but no one could agree on what to do to fix it. And it's really not unlike the whole debate that's been occurring in healthcare more broadly, is we can all point to all the deficiencies or problems in the system, but how you go about fixing them is much harder to come to. But just this in the next slide, a quick overview. Care was fragmented. It was very hospital-centric, specialist-based, episodic, reactionary, long wait times often. People had to travel long distances. In some facilities, there were even places in the parking lot where people who had motorhomes could park because they might be there for 2 or 3 or 4 or 5 days as they got their appointment. Quality was very irregular and unpredictable, and often not at the level that one would hope. Costs were rising. The value proposition was not particularly good. Very bureaucratic, very centralized, hierarchical management, extreme micromanagement from Washington, but one of the most unaccountable organizations I've ever seen. Which seems like somewhat of a paradox, although when you think about it, it makes absolute sense, because if you don't empower people to make decisions, then who makes them? And I could cite a number of examples where decisions were put off for years and went to Washington for a decision to be made, which meant it went into a big black hole. And some years later, at which point events had overcome the need for the decision often, something was made. The culture of the organization was very punitive, very risk adverse, which meant there was little innovation, because what happens when you innovate? Things don't work sometimes. The government has very little tolerance for things that don't work, and they usually let people know, and there's always someone to get on the soapbox and talk about the bureaucracy and why, well, I won't go there. You all know that story. Leadership of the organization frequently turned over. It wasn't always selected on the basis of demonstrated competence, as is often the case with political appointment systems. The capital investment decisions were very politicized and sometimes didn't match with where the needs were because there were other agendas at play. The governing board, most of whom could spell VA, but it didn't go much beyond that, had generally little knowledge. And by the way, who's the governing board of the VA? All 537 or so? Yeah, the Congress. And very different views about what the organization should be doing, what its role is, what it was actually doing in the first place, what was different about veterans' healthcare needs versus the rest of the public, et cetera. And political agendas often got mired in real needs of the organization, and sometimes those needs didn't get addressed because of those political agendas. Overall, when I went there in 1994, it was a pretty unhappy place. Patients were unhappy, staff were very demoralized, Congress was, or at least some members of Congress were calling for its elimination. There was, overall, there wasn't a lot of happiness in the organization. So what I want to turn to now is what we did to change it, and indeed this article in and of itself has an interesting story. Fortune doesn't have a long history of writing flattering things about the government. So they had contracted with a freelance writer to write a story about the VA, and he came back and gave him his manuscript, and it was very positive. And they said, we can't publish this. It doesn't fit with basically our editorial priorities or needs. And so they didn't publish it. Now, he actually took it and turned it into a book in which he's made quite a bit of money off of. But in any case, 3 or 4 years later, they did the same thing. This time, they ended up publishing it, which was unusual to see a positive story in there in this venue. So I've given you the list of what was wrong, kind of the complexity of the organization. So where do you start? If you're at the helm of an organization like this, and I know that time doesn't really allow us to have a dialogue or a conversation, but it's really the same place you start in any other change project. You start with the vision. I mean, what do you want to do that's different? Now, to get there, you have to do a lot of other things about learning about the problems and engaging people, and there's a lot that goes into it, but any change effort starts with the vision of what the new future should look like, or at least what you hope it will look like, and then enlisting people in that effort so that it becomes a shared vision. What you see on the right-hand side of the slide is what basically the vision as it was articulated. At that time, I would ask you to read it and think about how many parts are there to that. Because a vision and a vision statement is only as good as it's actionable, and insofar as it gives direction to what you need to do and where you need to go. So, how many parts are there to this, would you say? I see 1, 2, 5, 7. Well, I mean, we could quibble over it because it depends on how you count the words. I view it as having 5 parts, basically. It laid out 5 strategic objectives. We wanted a seamless continuum of care, which is you do certain things to create that. We wanted consistent and predictable performance, but we wanted high quality. You could have consistent and predictable poor quality, but one might argue why that would be a goal you would aspire to. We wanted care to be patient-centered, which at that time, I mean, if you go back, this is almost 20 years ago, this idea of patient-centered care was a very new concept that people really didn't understand. And then we wanted to provide superior value. And that really laid out the agenda for how we were going to proceed. There were some other, or some end results that we hoped to achieve. You know, we wanted the system to demonstrate good health care value that was equal or better than provided in the private sector. I mean, why should, as a taxpayer, and this wasn't a terribly popular view, I should acknowledge, when I went there, but, you know, as a taxpayer, why would I want to support a system that didn't provide as good a care as could be provided in the private sector? It's kind of a simple question. We wanted superior quality to be predictable and consistent. Indeed, the hallmark of any high-performing organization is consistency and predictability of the results. We wanted system-wide and local performance goals and expectations to be clearly identified so that people actually knew what was expected. We were going to measure performance and hope to continuously improve it. And we wanted to move decision-making to the lowest possible level, or the lowest appropriate level in the organization, which meant getting rid of a lot of things that were or had historically been decided in Washington. Since value was very much a part of this conversation and where we were going, it's, you know, what was value? How do you define healthcare value? And so I put forth this, what became known as the value equation. You know, how is value defined in Econ 101? Quality over cost. I mean, that's the basic equation. But then the question becomes, what's quality in healthcare? And that's where it gets a little bit more complicated. And again, if you turn the clock back to the early 1990s, people were still debating in that time, can you measure healthcare quality? That's an argument or a discussion of only historical interest now, but at the time people still debated this and spent hours very vehemently. But we defined it basically that the value, the denominator would be cost or expenditure, and the numerator would consist of these 4 domains: the accessibility to care, both geographically and temporally; the technical quality, the things that doctors and nurses are often focused on, hemoglobin A1Cs and beta blockers after MI, and, you know, the long list now of quality metrics; functional status, the 3rd domain, how well were people actually functioning at the end of a year, and we could track that. Indeed, one of the things that we're looking at in the Medicare-Medicaid dual eligible project is how do we assess functionality in that population, and there are standardized instruments that you can use to do that. And then last, service satisfaction, patient satisfaction, customer satisfaction. People use other names, but we used service satisfaction. So once you have the vision, what do you do? I mean, what's kind of, as you think through this, there's a logical sequence here. What's the next step? It's not a hard question. You have to have a plan, the roadmap. How are you going to execute that vision? And that, our vision originally was articulated in a document called Prescription or Vision for Change. And then the sequel, never made it quite as a bestseller, but You can buy it on Amazon. But the sequel was Prescription for Change, which laid out many of the tactics and the strategies that we were going to use, mission goals, guiding principles. And I felt that when we talked about strategic objectives and actions, they should all be tied back to principles. So every chapter begins with a delineation of what the guiding principles are, which is also predicated on what the values were behind that. And our basic change strategy included these 5 directions. We wanted to increase accountability, we wanted to integrate and coordinate care, we wanted to improve and standardize superior quality, modernize information management, and then align finances with the desired outcomes. Each of which then, as a strategic objective, had a menu of tactics by which it could be hopefully operationalized. So what are and time really doesn't allow us to spend time talking about these, so I'm just going to hit some high points very, very quickly. But the first strategic objective was to increase accountability. So then you said, okay, so what are the tactics? If that's my strategy, what are the tactics for operationalizing that strategy? One of our first and biggest problems was to create a new management structure that actually built in accountability. At the time, when I went there, the country was divided into quadrants, and there were 4 regions that typically had 40 to 45 hospitals in them and a whole lot of other facilities. What was the likelihood that that regional director knew what was going on in any of those hospitals? 0. I mean, it was impossible. Just too much going on. So one of the first things was to change the structure. We implemented a new performance management system, which I wish I could have made more complicated because quite a few $1 million have been spent evaluating it. But it's basically, we had a vision, we had strategic objectives, we were measuring performance, and managers were assessed on their performance, and they either met and we actually had negotiated management contracts or performance contracts every year. They either met what was in there based on the numbers, or they didn't. And it changed the argument from whether, you're a nice guy and we know you had a tough job, very subjective, and it was, here are the numbers, you either met it or didn't, and then we could talk about what we might do about it. And then we worked a lot to ensure consistency in messaging and communications. In many healthcare facilities, for those of you in healthcare recognize this, the CEO says something about, we've got to improve quality, we've got to improve satisfaction, we're going to do all these good altruistic things. The CFO comes along and says, nice, but we can't afford it, and money's going to go for other things. Inherent conflicts in the messages, and so it's important to get the messaging in all the various ways that messages are communicated in an organization consistent. I'm going to kind of blow through this, but our new management structure, the reason for mentioning this is that the VISNs, or the Veterans Integrated Service Networks that were established and laid out in the Vision for Change document, are an awful lot like accountable care organizations today. If you read the verbiage that's in here, we're going to place a premium on improved patient service, rigorous cost management process, best value care. These are quotes from the document. Utilize data-driven measures to manage total performance, patient-centered, improve the overall health and functionality of the population. Hospitals are going to have a less visible place, and that we're going to think of more coordinated community-based networks of care. I mean, if you pull out the ACO literature, you see an awful lot of this, and not ironically, one of the individuals who's often considered the fathers of ACOs worked for the VA at this time. But in any case, that's another conversation. Basically, it divided the country into these regional areas that had an array of assets, 7 to 10 hospitals, some long-term care facilities, et cetera, and a defined population. So that became the new management structure that continues to be in place today. Shifting gears, the second strategic objective was to integrate and coordinate care. And again, there were a number of tactics that were operationalized or were used to operationalize that. We implemented universal primary care. In 1994, 10% of VA patients were enrolled or covered in managed or in primary care. Not unexpectedly, as a very academically oriented organization and affiliated with most of the academic health centers in the country, primary care wasn't the first thing that people thought about when they went there. So we actually had to start laying off physicians, very competent, very qualified, sometimes world-renowned infectious disease specialists or endocrinologists, to hire general internists or other primary care practitioners, because we didn't need so many specialists and we needed more primary care physicians, which also created some interesting dynamics, people out with their signs and demonstrating, but it was what was needed for the organization. We had to work with Congress to change some of the silly laws that existed at that time, put in place service lines, and did a number of other things to try to integrate and coordinate care better. Focused a lot on improving quality. If there was one single goal, if you will, behind all of this, it was to improve the quality of care of the organization. It was a fundamental string throughout this. We implemented clinical performance measurement and public reporting. Again, lots of performance measurement today. It was a very lonely and isolated place in 1994, 1995. When we came up with some of the first performance metrics, they were indeed the first. Because, I mean, there were HEDIS and some other things were just coming into their own, but many of the things that we needed performance measures on simply didn't exist. So there was some effort put into, adapting existing ones, creating new ones. We put in place patient service standards, certainly a novel idea in the VA at that time. Patients shouldn't have to wait more than 30 minutes for their appointment. They shouldn't have to drive more than 30 miles to access care. I mean, there were a number of other things. Put in place a national formulary, and I won't take the time to go into kind of how a national formulary can be used as a quality improvement or instrument, but it's very different. Having run the Medi-Cal formulary for many years, which has a somewhat different philosophical flavor than how we went about it here, they really were somewhat different, and the outcomes were, in some cases, somewhat different. And that's not meant to disparage the Medi-Cal formulary, but there are other factors that often drive what's covered on those decisions and necessarily what may be well, leave it at that. Did a number of other things to try to improve quality of care, particularly for some of the particularly high-impact populations, cancer and pain. VA was, I believe, the first large healthcare system in the nation to implement pain as the fifth vital sign in 1998, which again was very almost unheard of. Let me leave it at that. Some tactics for modernizing information management. This, particularly I think for this group, should be a no-brainer. Top of the list was implementing a system-wide electronic health record. Actually, when I went to VA, having not been with it for a long time, when I was a house officer and a medical student in the 1970s, I had rotated through the VA, as do most medical students and residents, but hadn't been back in a long time. And found that they actually had an in-house electronic health record that had been developed. It wasn't ready for prime time, but we looked at what was available commercially, ultimately decided to go with what became CPRS Vista. It took a couple of years to get it up to speed before we deployed it, but that was a very high priority. We did a number of other things as far as standardizing IT systems and databases, large number of databases. Implemented a semismart registration card, a little card with a chip that had 8 data elements in it. We had a long debate about whether you go with a smart card with lots of information or just use one, but if you have a centralized electronic health record, all you need really is to be able to access that, and you can do that with much less data on a chip. Finally, the last tactic had to do with how did we align finances with the desired outcomes? This is probably the area that has received the least attention in this transformation, but we went to a new capitation-based or global payment system. And it's been tinkered with over the years, but they continue to use what is known as VERA, a Veterans Equitable Resource Allocation System, which really shifted hundreds of millions of dollars around the country. Indeed, this is one of those things where the Congress filibustered to try to prevent it from happening. We anticipated that, had worked with leading senators from Florida and Texas and some other places, so that by the time it got to the floor and people were registered on it, there was enough momentum to actually carry it through the filibuster, and one of those long political intrigue stories. We focused a lot on reducing waste and duplication and other sorts of things, and some of what many people found novel is we really focused on health promotion and disease prevention, which, considering the disease burden of the population, many people found surprising. But it may not be primary prevention. There are areas where we could do that, but tertiary and secondary prevention, i.e. keeping people out of the hospital and keeping them functioning, is very important as well. And many of our efforts focused more on secondary and tertiary prevention, but it was the same idea that we want to keep people as healthy as possible and as functional as possible. So fast forward, after a rather tumultuous and contentious several years, what were some of the results? Well, by the end of that time, we were treating 24% more patients. We had reduced staffing by about 26,000 staff, although the proportion of caregivers had significantly increased. We had implemented universal primary care. We had closed more than half of all of the acute care hospital beds, 29,000 beds, which at the time, there was only one other healthcare system in the nation that had 29,000 beds. We opened a bunch of new, several hundred new community-based clinics, substantially reduced waiting times and improved access. The formulary that was put in place, we could quantify that the annual savings, at least after 5 years, was about $650 million a year in the purchase price of drugs. However, I would be quick to note that we got rid of those cost savings very quickly. For example, when the protease inhibitors came on the market in the late 1990s, and you may not know, but VA is the largest provider of care for HIV, AIDS, certainly in the US, if not the world. It was about a 10-second decision as to whether to add the protease inhibitors to the formulary, but that was several hundreds of millions of dollars per year. Likewise, when interferon became available for hepatitis C, and again, veterans are disproportionately affected with hepatitis C, prevalence of 24% or so in some of the sub-veteran populations. Again, a very quick decision, but one that cost many hundreds of millions of dollars. We reduced bed days of care per 1,000 patients, a standard metric in healthcare, by 68%, reduced inpatient admissions by over 350,000 fewer admissions per year. Indeed, this is, some people call it the X-bar or X-graph. I don't know how well it projects, but the red line shows inpatient admissions, which in 1993-94 was running well over 1 million admissions a year. And by 1999 was about 620,000. The number of ambulatory care visits had increased from 24 million to 37 million. They're currently running about 60 million a year, although there's twice as many people using the system as there was at this time. So there was a major shift in care from the inpatient to the outpatient setting, and the quality metrics were very supportive of that change as well. We did implement the electronic health record in all 172 hospitals, basically in 6 tranches of 6 months each, and so the entire system went live in actually 35 months, not quite 3 years. I mentioned the smart card. We reduced a lot of the bureaucracy, if you will. Got rid of almost 3,000 different forms that were used. Actually, I tracked this. This was one of those organizational metrics that we tracked on a monthly basis. Which meant that we still only had about 1,000 too many, but it was a big dent, and we merged over 50 hospitals into some multi-campus local facilities. Even GAO, which is not accustomed to saying good things about government, indeed their reason for existing is to find fault in how you can do things better, but they had to acknowledge that in the 3-year period, 1996 to 1998, we had reduced our operating costs by over $1 billion a year. I think they were quite conservative, but I'll take it whatever they said. And we were able to demonstrate a little over 25% reduction in per patient annual expenditures during this time. And concomitant with this, which you might view as kind of fiscal or other not necessarily patient-friendly statistics, but patients liked the results. The customer satisfaction ratings were much higher than they had been before. During in 1999, 80% of respondents said they thought care was better. There were marked improvements in quality and safety, and again, time doesn't allow to go through some of those numbers. I would assure you that there are dozens and dozens of papers in the peer-reviewed literature that have documented the improvements in quality that have occurred from this time and to today. They're still doing better. Indeed, an article like this in Business Week, I don't know, this is 2004 or 5, something like that. At least when I was a resident rotating through the VAs, getting an article like that would have been totally delusional, even with the assistance of chemicals. Again, you take it wherever you can. Because this always comes up, I should note the question is how much money was allocated to make these changes? And the answer is none. In essence, during this period of time, no money at all was appropriated. I had a handshake deal with a senior official in OMB who, and since she still works for the White House, I won't give her name because this was questionably legal, I suppose, but who said that whatever savings you accrue, you can reinvest in the system, as opposed to turning them back to the Treasury, which had been the marching orders every year before that. And what's the incentive if you're going to save money and turn it back to the Treasury? What's the incentive to save money? Zero. So, I mean, this, and in many ways, this is kind of what's being played out again, the shared savings approach, or gain sharing, you put it under different names, but, just to put some numbers around that, in the 5 years before the changes were implemented, the budget went up 37%. Number of users actually stayed the same or decreased. During the 5 years that this was going on, the budget went up 10%. Healthcare inflation was running 6% a year. You can do the math as to what that means if you compound 6% over 5 years. A 10% net increase over 10 years means that you took a substantial cut. And then in the 5 years after this, the budget went up 45%, but that was also concomitant with essentially a doubling of the number of users. I mean, this was a case where veterans were voting with their feet, and the enrollees went from, when I left, at a little less than 5 million to over 8 million in a period of 3 years before enrollment was turned off for all but a few categories of veterans. So let me, in the remaining few minutes, a few observations or lessons perhaps that might come out of this. One, which many people or is somewhat counterintuitive, is that public hospitals can, in fact, provide very high-quality care. They can do it efficiently, and quality and their overall performance may well be superior to that of the private sector. This has been, we have other data from other public systems today that have shown that as well. Denver Health might be in that category, but there are others more recently that have demonstrated that. Rapid and very substantial improvement can occur in these large, politically sensitive, financially stressed public systems that are under the microscope. It is possible to achieve rather dramatic change in public systems in a short period of time. I think one of the important lessons, certainly for healthcare, is that what we should expect when we embark on these types of change efforts is that care, the quality of care will improve, patient satisfaction will get better, and costs should go down. Indeed, we should be able to achieve all three. That should be the default position. Certainly during the several years I was head of the National Quality Forum, the typical conversation was, well, we can improve quality or we can improve service satisfaction, but you got to pay us more. That way of thinking is rapidly becoming anachronistic, and we really have to focus on how do we achieve all three. Indeed, this is not dissimilar to the triple aim that's being actualized today. The need for a shared vision and very clear strategic objectives as to what is expected was clearly a lesson here that repeatedly people have commented, largely internal in the organizations, that it was very clear what we were supposed to do. The marching orders were clear. The kind of the concomitant of this, and one of the tensions that's often more difficult in government, is what's the balance between direction and mandating things, you know, the top-down versus the bottom-up approach, and finding that right balance. I think we did relatively well here in setting clear expectations, what we wanted as the outcome, trying to enable it insofar as we could, but then letting people figure out how to do it on their own, and particularly in a national system like VA. You know, providing care in Anchorage is different than Manhattan, which is different than Miami or Los Angeles, and you know, so there needs to be a fair amount of flexibility and latitude to to figure out what works best locally. The need for a very clear and actionable strategy. You know, in complex adaptive systems like healthcare, when you really are focusing on key change levers, it's important that they be aligned and that they complement each other. Indeed, they may be overlapping, but they reinforce each other, and that's part of what we were doing here, I think. And when we look at those strategic objectives, there was not only alignment, but they reinforced each other as success was achieved in the individual areas. Public reporting, I think, is important. The literature is mixed on this right now as far as what is the value or the benefit in driving change of public reporting of performance. I think the literature just hasn't caught up yet with the reality, particularly in healthcare. The need for electronic health records, other automated information systems. Hopefully that's not a hard sell in this setting, but certainly in healthcare, which stands as probably one of the most information-intense and knowledge-based activities that human beings have ever engaged in. So having those aids is critically important. We can achieve integration either vertically, and VA is often considered a classic example of vertical integration where you own all of the assets, but you can do it just as well functioning virtually. And indeed, much of, as this played out, that we had a lot of virtual integration. Virtual integration is pioneered by the biotechnology companies working with the big pharmaceutical companies, and the management agreements, the information systems, the contractual terms, those are the glue that holds virtual integration together. But it's simply not necessary either to employ people. I mean, one of the biggest questions in healthcare today is, should we employ doctors? At least in the other 49 states. California, that's not allowed at the moment. It's not legal, and a couple of other states fall in that category. But there's been a huge rise in employment of physicians, and many health systems are finding that that really isn't producing the benefit or the alignment that they had hoped, and indeed you don't have to. The need for frontline people, and in this case frontline clinicians, to be involved in the process seems to be a lesson that is learned and relearned over and over again. And some managers are still surprised when they found out their latest and great idea for what should be done, and when they implemented it and forced it upon everybody and it didn't work, they're surprised that they overlooked something, or they didn't get buy-in with the people that were going to have to execute it. But it's surprising how often that still happens. One of the decisions that we made relatively early on in this process was, do we focus on individuals or do we focus on organizational performance? And we made the decision to focus on the aggregate performance, the organization, which might be a unit or a ward or a hospital or a clinic, as opposed to doctor or nurse X or someone else. And I think that we did well by making that choice. Certainly, as more and more work is done in teams, we really have to look at the aggregate output as opposed to necessarily individuals. And I think this is the last or next to the last. The need to include training and education in any change process like this, essential ingredients. This was a never-ending fight in doing this, because when you look at your budget, where does training and education fit in? I mean, it's typically an administrative cost. What's the first area that everybody wants to cut? Administrative costs. So our folks actually got quite good at hiding things and burying these in other categories. But it's, you know, we should understand and just accept that if we want people to do things differently, you have to provide them the skills and the knowledge to do it differently. Again, for some of the green eyeshade types, that continues to be a hard concept. The need to decentralize responsibility and authority, I think, is very important. I think you should move decisions out as far as possible. But when you do that, it has to be very well understood what are the mission critical elements that you just can't fail on. You can't let people fall through the cracks, and that has to be very clear if you're going to do that decentralization. I won't go into complexity theory and complex adaptive system. The last point I would make here is simply the essentiality of aligning finances. And as much as we might like to think about healthcare being an altruistic activity and people are doing there because we want to serve humanity and good things, we have to get the dollars and cents flowing in the right direction well. One of the things that was so important about going to the global payment system, it actually built in incentives to save money, because if you provided too much care, you ended up costing you. If you provided too little care, it provided. So it really set the tone to find the right amount of care, and then provided flexibility to shift any savings into other areas, but it all stayed in the system. Any savings went to improve the basic delivery process. So let me stop there. I think I've used up all the time that I had. If Daniel, if there's time, I'll take questions. If not, thank you very much for the chance to be here.
I'm just wondering, because you didn't mention it, and I know it's not your fault because you haven't been there in some time, but can you comment on this current state of affairs at the VA? They've certainly been in the news much lately because of issues.
Yeah, and so many of the issues really relates to benefits, which there's another sub-cabinet agency called the Veterans Benefit Administration that does the benefits. And their performance is not, hasn't received a lot of accolades lately. And the amount of claims back up. Now, the complexity of claims has increased dramatically, and there's a lot of reasons, but nonetheless, the performance is less than it should be. And unfortunately, that covers or colors the perception of the organization. Most people actually are quite satisfied and happy with the health care. It's just getting into it and getting to the point where they can actually get the services. Now, like with any service area or any health care, not everyone's happy, and things happen that sometimes you wish they didn't. But the major criticism, and I think where the system has legitimately been criticized, has to do with processing of claims, which candidly I don't understand why it's so hard, other than that I know that the system of benefits and assessing people for disability is from the Civil War. I'm not kidding you. I mean, it was codified post-World War I, and they're using the same system that was codified after World War I, but what was done for World War I was what was done in the Civil War. So that actually is part of the problem, and how you determine 10% increments in disability, and what does it mean to be disabled today? And I mean, there's a need to modernize I think at least much of the thinking behind the whole disability and system. But we could have a long conversation about that. There are other things. The mental health issues have challenged VA. The number, the PTSD and all the comorbidities that go with that. But, I've sat on a number of Institute of Medicine committees actually looking at these issues, and we released a report a couple months ago, and, if you compare it to the private sector and what you can get in the private sector, it actually looks pretty good. You know, for all of its flaws and weaknesses that there may be, the gold standard doesn't necessarily exist elsewhere. You know, there are many areas where the availability of psychiatric care, certainly for those who don't have good indemnity insurance, whether they're on Medicaid or something else, is all but non-existent. Yeah.
You mentioned that the VA system is a large You mentioned the word adaptive system or complex system, and one of the things that I'm learning in dealing with adaptive problems is that there's not really consensus among a lot of the stakeholders that are involved as to what the real problems are. And you mentioned at the top of your presentation that there was no argument as to what these problems were, and so I'm kind of wondering what that set of dialogues that you had with the various stakeholder groups that you had regarding identifying the problems that you were contending with and dealing with solutions. I mean, everybody in here is connected to human service systems that, you know, have rather large stakeholder constituencies that it's really hard to get to. It's hard to get to the place where we can all agree on what the problems are before we even talk about solutions.
No, I'm sympathetic. Two responses, somewhat different. My reference to complex adaptive systems was to healthcare in general, and to distinguish it from the more linear manufacturing models. And the importance of that is how you go about changing a complex adaptive system, and what that means is very different than how you go about changing a linear manufacturing process where you control things, and if you change this, then you can get a predictable change here. In a complex adaptive system where you have people with very different ideas and aspirations and, you know, view the world differently and are competing and are learning and changing, you know, you have to use a different set of rules and approaches to it. That's the essence there, and I forgive me for not making that clear. The process, and when I went there, you know, it was very clear that we had to come up with a new structure, management structure, immediately. And so actually the consensus process that continued throughout the tenure on different things, but really began with, okay, what's the new management structure? And the maybe not to belabor that, but the process I utilized, I had my idea of kind of where I thought it should go, but instead of coming in and saying, okay, we're going to do it the Kizer way, and you know, everyone get in line and, you know, start marching in that direction, I made a number of criteria which everyone could agree upon that those were desirable attributes of what the new system or the new management organizational system should look like. Then I brought in a bunch of people from throughout the country who were viewed as kind of thought leaders, or, you know, they were respected by their peers, and literally put them in a hotel in Washington, and I can't say I locked the door, but, you know, they got bread and water for a week until they came out with a new structure. Now, we met a few times in the interim, but what they came out with was essentially what I kind of would have hoped they would. But the importance was that it wasn't then my idea, but it was the idea of this group of 20 or so individuals who then, because they already were intellectually vested in it, could go out and start proselytizing and evangelizing and all, whatever those right words are, to selling the idea to the rest of the organization. Now, we had to, you know, once we did that, we had to write it up and get Congress to agree on it, and, you know, there was a bunch of process. But during that process, it was socialized with a large number of organizations and people, and so by the time it actually came time to implement it, there was pretty good buy-in. You know, it wasn't universal. You'll never get universal buy-in, but it was more than sufficient to move forward. And then we kind of use similar processes for other things as we move forward.
You mentioned in passing that the VA doesn't have a responsibility for dependents, as DOD does, with several 100,000 children of recent veterans affected by the trauma that you mentioned. Is it feasible for the VA not to become a provider, but to be a more active convener of state and local networks to serve that very large group of children affected by trauma and substance use.
Yeah, actually, that was one of the recommendations in our recent report on the readjustment issues was had much along those lines. Historically, VA has been statutorily precluded from providing care for spouses or dependents because the thinking was that the system can't accommodate all the veterans who need care, so we can't open it up, to non-veterans. Now that actually, with the Affordable Care Act and the broader insurance coverage, that dynamic may change as well, because there are now other options, as well as increasing recognition that these health issues, particularly some of the mental health and serious disabilities that are being taken care of now, are really family issues. It's much more than the individual, and that, I mean, that's always been the case, but there's a growing recognition, I think, understanding of that. So, I would be guardedly optimistic that there may be some changes in the future, and there's, there actually has been some changes there as far as compensating caregivers and other things. See where it goes. I mean, along those lines, the whole idea of VA and DoD having separate healthcare systems, which take care of the same individual at different points in their life, is something that is going to have to be reconsidered as well. But I won't go there right now.